Welcome back. Today is another special edition of Healthline 3, and we are talking with the Chief of Obstetrics for Willis-Knighton Health System, Dr. Rodney Armand. Welcome aboard.
Thank you, Luana. Nice to be here.
It's always good to have you on. Armand, I said it correctly?
You did.
All right, it's my first time really getting to do our first Healthline 3 together, but I'm excited about this because you're incredibly knowledgeable and you're talking about a topic that's near and dear to my heart, pregnancy.
Absolutely.
I think a lot of women out there, no matter what age they are, they want to make sure that they have a great and successful pregnancy. So you say this starts really early, far earlier than when you think about conceiving.
Absolutely. So, you know, in the United States, probably about half of pregnancies are, I would say, unintended, which doesn't mean they're not desirable or not wanted, but they were kind of I wasn't planning on that.
Right.
And so I tell patients that when you're in the window of time where you're looking to start thinking about the fact that you want to be pregnant, you really need to plan that out, preferably about 9 to 12 months out in advance. I always encourage patients to get an appointment with their OBGYN if they don't have one, to establish a relationship with one, because there's several things that you need to do before you conceive, or you need to consider or look at it with the help of your physician. One of those is a prenatal vitamin. I tell patients that prenatal vitamins we think of them as something you take when you're pregnant. However, the maximum benefit of a prenatal vitamin is actually really early in the pregnancy.
And that's because what mom makes sure that her body is at optimal levels and you know, everything is at its optimal peak.
Absolutely. You know, with the
does this get passed down to the baby?
Right. You know, with the prenatal vitamin, the folic acid within that reduces your chances of a neural tube defect, but that occurs around the first 4 weeks of pregnancy.
Wow.
So by the time you realize you're pregnant, you may be already out of the window when you have a maximum benefit for that. So I tell all reproductive age patients, roughly 15 to age 45, 15 to 50, you should be on a daily prenatal vitamin.
All right, let's talk a little bit about people who are having trouble conceiving. When do they need to let their doctor know? Sure.
So in the United States, fecundity, which is your chances of getting pregnant per cycle, is about 20%. About 1 in 5 menstrual cycles you will conceive if you're trying. About 85 to 90% of couples that are young and healthy will conceive in the first 12 months. So I tell patients, if you haven't conceived and you're actively trying to get pregnant, you should pursue a workup for that. If you're hitting around 35 or older, I tell patients that number needs to be closer to 6 months, and that's just because we may be dealing with a shorter window of fertility there, and we'll want to initiate that workup a little sooner.
So they should already be seeing their OBGYN, because they were hopefully doing that pre-planning already.
Absolutely, preferably, yes.
So we typically go to our OBGYN once a year. What do we need to do differently when it comes to now thinking of conceiving? Do we need to see you much more often?
Well, no, I think once a year is still a good number to shoot for. But you know, if you're specifically at that annual appointment, your OBGYN should be talking to you about, if you're not trying to get pregnant, should be talking to you about contraceptive options, and if you are, should look at your total health background. Do you have chronic hypertension? Do you have diabetes? Do you smoke? Should you maybe cut back on your alcohol intake? If you have diabetes, certainly it's very important, if you're looking to conceive, to have well-controlled blood sugars, because if your sugars are poorly controlled around the time of conception, you have to remember that the baby's organs are forming between 3 and 10 weeks. And so if you're at a high glucose level during that conception period, that could have long-term impacts on the baby. And so those are just a few of the things that you and your doctor should be looking at as you're trying to conceive.
And this is just as that little baby is being formed. I mean, in its wee stages, not even, showing yet.
Absolutely. In fact, most of the organs of the baby are forming before you'll ever show. They're already forming.
Okay, it's just.
Yes, not trying to
I
make
feel
you
like
not
I
trying to
know
make you
a
nervous.
lot already, and then I'm starting to realize, oh no, wait, you really don't know that much. So
Right. So there's a lot that goes on early in conception that's really important.
So a lot of people have now been talking about the gender of the baby. Why is it that people would want to know ahead of time, and why is it important to talk about it?
So we used to typically pick up the gender of the baby at a big, at the anatomy scan, we call it, and we still do in a lot of cases, and that's typically done around 18 to 20 weeks. And we do that in conjunction with looking at the remainder of the anatomy of the baby, the heart, the kidneys, the brain, the neural tube, the spinal cord, all of those structures. And we used to pick up the gender at that appointment. But today we now have the ability to pick up the gender of a baby as early as 10 weeks with an amazing technology called cell-free fetal DNA, which is we draw blood from mom, but believe it or not, fragments of the DNA of the baby are already going through the small little placenta and getting into mom's bloodstream, and we're able to pick up the genetic material of the baby and tell you the actual gender of the baby at
Wow.
10 weeks. So I think your question was, do we need to know the gender early on? It's very rare from a medical, from taking care of your pregnancy, that we need to know that.
It's more for picking the color scheme of the
It's-
baby's bedroom.
Yes, which is just as important. Don't get me wrong, I understand that. But we are able to pick up other conditions that might put the baby at risk
During that 10-week.
during that window. And,
Okay.
and that leads into a discussion of some patients, and this is a very complex discussion to have about continuing a pregnancy, not continuing a pregnancy. But beyond that, with the thought of, regardless of what your decision would be in that circumstance, I think it's very important for patients to know that in advance, because if they're going to have a child with special needs, it would be good to prepare themselves for that, to read up on that, and just to understand all of the ramifications of that during the pregnancy rather than to finding out at the very end.
Absolutely. What constitutes a high-risk pregnancy?
That's a very good question.
Is it a loaded question?
It's not really loaded, but it's a good question. So we throw that term around as obstetricians. We'll say, well, you're high risk. Really, high risk to me defines a pregnancy that's going to have additional studies, imaging, testing done during the pregnancy that we don't routinely do. So for a routine pregnancy, we typically see you sometime between 8 to 10 times in a pregnancy. There are conditions such as hypertension or diabetes, as an example, or multiple gestation twins, where the baby is at more risk, or the babies are at more risk for growth restriction, preterm labor, unfortunately intrauterine fetal demise, those sorts of things.
And you can tell all of this. You can see this through the testing.
Well, through the testing, what you do with, as an example, with ultrasound is we look to see with twins, we may be following whether or not twin A is growing too little in comparison to twin B. We call that discordance, when you see a difference in the sizes of the twins that goes beyond a certain value. Or you can make sure there's adequate amniotic fluid around the baby. We do what's called a biophysical profile, where we look at the actual breathing motions of the babies in utero and their movement. So there's a number of things we do with ultrasound. We also have what's called non-stress testing, where we put a little monitor on your abdomen and watch the baby's heart rate, and we're trained to look at that heart rate and tell, does that look appropriate? Has it got enough variability? Do we see accelerations on that heart tracing? So there's a lot that we can do, and in using that, the purpose that we utilize all of that testing and imaging for is, most pregnancies we're trying to get you to 39 or 40 weeks, so get you too near your due date. But with certain medical conditions, we're always looking at the health of the mother versus the health of the baby, and always trying to decide when is the optimum time to deliver this baby. And sometimes with those conditions, we have to deliver the baby sooner.
My goodness. And then again, how do you constitute, when you mean high risk, are you looking at the baby as high risk or mom as high risk? Mom may have done some things or not done some things to
Right.
really plan and prepare.
The answer is yes.
To all of that.
So the answer is it's both, right? When you're looking at a pregnancy, you're looking at pregnancy can put some stressors on the mom, depending on her medical health. So sometimes we have to deliver a baby early because of stressors that are being put on the mom's body.
So typically, or I'm just making a suggestion here, somebody who's diabetic maybe?
Absolutely. So we may see that in terms of diabetes, a lot of times the mom may have inadequate control of her blood sugars, and you're actually in that case worried about the baby a little more actually than the mother, because if the baby's in an environment where the blood sugar is really high, a couple of things can happen. The baby can get what's called macrosomia, where the baby's big, and that can make delivery difficult for mom, and it could put the baby at increased risk of shoulder dystocia, which is where you deliver the baby's head and have difficulty delivering the rest of the baby. And the other thing that can happen is the baby's blood sugar, the baby's been living in mom's blood sugar environment, and upon delivery, the baby's blood sugar will drop rapidly because the baby's been involved in a high insulin environment. And so diabetes is a condition where sometimes we have to deliver the baby a little early because of the exposure to the high sugar environment. Also, we can see growth restriction. Areas where we may see problem for mom may be she may have preeclampsia.
Okay.
So preeclampsia is a condition, a condition associated with high blood pressure in the mom, and spilling protein in the mom's urine, and can lead to seizure activity and loss of a baby. And so preeclampsia is something where we also frequently have to deliver both for the baby's safety and for the mom's safety.
How can a woman avoid preeclampsia? Preeclampsia is how I always want to say it, but
Yes, so the answer is the cure for delivery the cure for preeclampsia is delivery. Preeclampsia is one of these conditions that only occurs in female pregnant human beings. It doesn't occur in any other mammal, to our knowledge. It doesn't occur in any other species. It is unique to pregnant human beings.
And is it more common than people might think?
Well, I think most patients, when they become pregnant, they start reading about preeclampsia. Right. So it is common. We do. I mean, when I say that, it's not like it's more often than a pregnancy not complicated by preeclampsia. But if you look back in the history of what we call prenatal care, if you notice in prenatal care, we start off seeing patients roughly every 4 weeks. And then as we get further along, we see them every 2 weeks. And then towards the end of pregnancy, the last month, we're seeing them weekly. And that really stems from well over 100 years ago at Johns Hopkins, where they first started developing this. They noticed this condition in pregnant women where they developed hypertension. Their blood pressures would start to get higher and higher towards the end of pregnancy. And so that condition, preeclampsia, is what really got prenatal care off the table and began to get a generalized way of this is how we take care of pregnant patients. And this was the disease condition that kind of started that.
And how does a mother get preeclampsia? Is she conditioned for this? Is it something that's passed down? Is it a gene?
It may have a minimal genetic impact, but mostly we believe, and this is still something in investigate, we're continually trying to find out what is the root cause of preeclampsia. Well, we do know that it's related to pregnancy, and so there's a lot of investigation into the impact of the placenta on the development of preeclampsia. Hence, when you deliver and the placenta is no longer in your body, most women will begin to recover from this process relatively quickly.
Okay.
So there's not a thing we can do to prevent it yet, and we've been working on that for a long time. What we have to do in the meantime as obstetricians is watch you closely, keep a suspicious mind out for that condition. There are variations of it. Just because you develop it doesn't automatically mean that we deliver you that day, but it's rare that we'll go beyond 37 weeks of gestation if you have that diagnosis, and a lot of times we have to deliver you a lot sooner than that if you have a severe a variance of that.
So the hypertension, nothing to do with how mom is eating. She's not eating overly fatty foods all of a sudden, or wait.
Yeah, so there are different
that
types.
chocolate.
Yes, right, exactly. You can eat all the salt and fatty food you want. No, so there are different flavors of hypertension. There is what we call chronic hypertension, which is you came to me before you were pregnant, your blood pressure was high, and surprise, surprise, you're pregnant and it's still high. So we call that chronic hypertension.
Okay.
There's what's called pregnancy-induced hypertension, which is you didn't have high blood pressure before you came to see me. Now you're developing some hypertension during pregnancy, but you don't have the other findings that we typically associate with preeclampsia, so you have that diagnosis all by itself. And then you have preeclampsia, which is this high blood pressure. And you can have variants of it as well, where you may have chronic hypertension when you come in, and then you get superimposed preeclampsia on top of that.
So there could be something with just the baby being in their period that's causing the blood pressure to go up.
Yes.
Not so much,
Right.
so there's nothing mom can do at home or differently.
Right. So what we again, and this comes back to preconception counseling, we try to optimize everything we can before you conceive. Do we need to have you on a medication for your blood pressure? And if we do we want to make sure we have you on something that is compatible with pregnancy? There's certain blood pressure medications we don't want you on if you're trying to conceive, and we want to try to make those changes before you conceive.
So is all of this part of what we hear commonly as a birth plan?
So
Or what is a birth plan?
Yeah, a birth plan is a birth plan. Typically, people think of that as something you get on the internet and you print up, and that is.
That's what I was thinking. Is he going to Harvard?
I will joke with you, right? I'll joke with you and say a birth plan is the bane of OBGYNs, but I'm joking with that. But a birth plan is typically something that people will print up. A lot of times we see this with the first pregnancy. By the time the second pregnancy is there, they toss the birth plan out the window. But a birth plan is, what I tell patients a birth plan should be is this. It should be a dialogue, a discussion with your physician during the course of the pregnancy, such that you've developed trust in your physician and you have an understanding of their thoughts and they have an understanding of your desires. But in summary, a birth plan is something that a lot of people will say, I don't want a C-section, or it's kind of a list of wishes for your delivery.
Oh, okay.
Okay, so
I want to do it naturally.
I want to do it naturally. I don't want an epidural. I don't want a C-section. I don't want this. I don't want that.
Until that moment comes, and all of a sudden you're screaming bloody murder.
Right. And so when I say it's a dialogue, what I mean by that is, you should, if you have printed off a birth plan, it's absolutely important to go to your doctor and review that with them in advance. You don't want to bring it to them the day of the delivery and say, Dr. Armand, I'm going to have this baby, and these are my demands, and this is what I want, and thank you very much. When I review birth plans, one of the things, as an example for me, that I think is important is I always tell them IV access is a must. Like, we always need to have IV access, because I sometimes see that on birth plans, and the reason for that is being able to give you medications emergently during pregnancy is something that we need to be able to do. So these are some of the things you've got to be able to talk back and forth with your physician
So
about.
be prepared for when you come into that hospital, you're getting ready to give birth, get ready to just be set up for an IV, because something could occur during pregnancy.
Absolutely.
During the delivery, I'm sorry.
We think of delivering babies, and for the most part, one of the things I love about obstetrics is that it is almost uniformly a happy experience, right? It's lovely to deliver new life into the world. But sometimes it's almost like, I tell patients, it's almost like being a fireman. A lot of times firemen are able to be at the fire station. I visualize, and they're probably going to start throwing things at the TV at me now, but they're able to be there with their compadres, and then all of a sudden the alarm goes off and they got to hop in the truck and it's on, right?
Right.
So labor and delivery can be like that. Things can be going well, and all of a sudden we've got to go immediately from this nice, tranquil environment straight to the operating room, and we don't want to be trying to do things like start an IV in that setting. So,
Okay,
so
what
there are
needs to
certain,
be done and ready.
Right.
I don't know if, I'm sure you've heard of the Kardashians.
Yes.
There was an episode when one of the sisters, her water had broke.
Right.
And then you see her, she gets in the shower, she's taking her time, and in my head I'm thinking, this is crazy. That baby needs that fluid.
Right.
That they need that. So there's just so many things that I think we see on television that we need to learn. No, you needed to be at the hospital like immediately.
Right.
But so does that happen? Could I just be sitting around and my water breaks?
It happens all the time. So
and I scream and yell and everybody's grabbing stuff.
Right. So some people, when their water breaks, they think, well, I'm going to stay here until I'm absolutely in labor. But the challenge with that is we don't know if your baby's head down. So if your water breaks and your baby's not head down, then there could be a concern about the umbilical cord coming out. And the longer you go with your water broken and we don't know it's broken or we're not managing you, your risk of infection begins to climb and those sorts of things. So
okay.
certainly
so it's not like the baby's not breathing in that moment, but
that's correct, right?
Okay.
But your water breaking is one of the things your OB should have told you. If your water breaks, you need to come to the hospital. You need to call us and come to the hospital.
Be there right away. My mom tells me this story constantly. I guess she told my dad, the baby's coming, she's coming, and he just took his sweet little time. And when they got to the hospital, I guess he sat my mom down on a bench outside while he went and parked the car, and my head was already there, and she screamed, yelling and screaming.
Every OB has their story of the delivery in the hall or the mom delivered in the ambulance on the way over, and of course that happens. That's not, I don't want people to be terrified that that's common. That's very uncommon for that to happen.
Right.
But it happens enough that yes, and there's a difference too. Typically, I tell patients there's a difference between a first-time mom and a mom that's had 4 or 5
and a
kids.
first-time dad who
Right.
decides to take his sweet time and get you to the
Absolutely,
hospital.
absolutely.
I was the first baby, clearly.
You were, okay.
They're no longer together anymore. We can see why. No. So all of this should be part of the birth plan. Definitely something to talk about with your physician. Make sure that you marry the right individual.
Yes, who will get you to the hospital.
On time.
On time.
So important. All right, I know that I'm not asking you all the questions. What are some of the things that you look at when you're looking at a mom's history? Why is that so important?
So, we start with, when I'm talking about pregnancy here, you look at, I look at their physical findings. What is their base, their BMI, their weight, height.
Body mass index.
Right? We look at their blood pressure, so their vital signs. That's what we look at kind of physically. I look at their obstetric history. Have you had a baby before? Was it a vaginal delivery? How much did that baby weigh? Did you have any complications during your pregnancy? As an obstetrician, when I look at a patient that's had a baby before, it's very reassuring if I've had a patient here that had a delivery, 8-pound baby 2 years ago, no complications.
Oh, that's a big baby.
Well, exactly. So that's the point, is that she's had a big baby before and she had no complications. It's unlikely, it doesn't mean she can't, but it's unlikely she'll have complications this time.
With the second one around
Right.
it. That one should just shoot right out.
That's exactly
That's the hope.
right.
We always want that to happen.
That's
All right. Let me ask you about VBAC and TOL. What exactly is that, and how do you feel about it?
A VBAC is what's called a vaginal birth after a cesarean section.
Okay.
And a TOL is just a trial of labor. So a lot of people use them interchangeably, but think of it as this: a patient's had a C-section before, and they come to you and they're saying, Dr. Arman, I want to have a vaginal delivery this time. I had a C-section last time. So what she's asking for is she's asking me for what's called a trial of labor. I want to try to have a laboring delivery, although I had a C-section last time. If we're successful, then she has had a vaginal birth after C-section. So the question is, do I think they're good? Absolutely, in the properly selected patient. So, yeah.
So, and when you say properly selected, it's because obviously mom had that C-section for a reason, or is it that once you've had a C-section, now it's difficult and more strain put on the stomach?
Sure. So we used to say, I'm getting older now, but 30 years ago, 40 years ago, used to say once a C-section, always a C-section.
Right. That's what I used to hear.
Right. Now, the reason for that is when you heal, when you have a scar on your uterus and you heal, that area is never quite as strong as the uterus was before. So you're taking a little risk when you labor a patient or labor a uterus that's had a scar on it. Okay.
Right.
That risk is low, though. That risk of having a problem with that is low. So, but nonetheless, when we do labor a patient that's had a C-section before, we're going to monitor them more intensely. We're going to have anesthesia in-house, and your OB is going to be in-house, and they're going to be there to make sure if anything didn't look right with the baby, we can proceed promptly to a C-section.
Okay.
So what I would say to patients is if you've had a vaginal delivery before and now you've had a C-section for another reason and you're on your third pregnancy, most likely you're going to be a good candidate for a VBAC.
Okay.
Okay, but it's a complicated counseling session that should go on with your physician, but I think our C-section rate in the United States is too high.
Even currently?
Even currently.
Okay.
And there's lots of reasons that we could that contribute to that, but certainly VBAC should be a tool in your physician's box if you're a good candidate for it, and they should be able to discuss that with you in great detail.
Let's talk a little bit about how can you help reduce a mom's chance of having the cesarean?
So
that we know, cesarean is a C-section, right?
That's right. Cesarean delivery is a C-section. So number one, like we talked about with preconception counseling, obesity increases your risk for C-section. Poor medical conditions such as poorly controlled diabetes or hypertension sometimes can force your physician's hand into having to do a C-section because of the condition of the baby. That's things that we can do early. Later in the pregnancy, things that are important for your obstetrician to do are to be patient. I tell patients it's a completely appropriate question when you're meeting an obstetrician for the first time. Ask them what their C-section rate is. Ask them what their primary C-section rate is, which is...
Why is it? That's so important.
Because you want to be able to compare. If they tell you my C-section rate's 20%, good. If they tell you my C-section rate's 50%, not necessarily bad, but maybe bad. You need to look at that.
When they say 50%, that means that's how many they've actually performed?
That means if they've seen 100 women, half of them had a C-section and the other half had a vaginal delivery.
That means that doctor is opting more often than not to do the C-section to begin with, and you don't want that. You want someone who's trying their best to stay away from that?
I would say it's one factor in many that you use to choose your OB.
Okay.
But patients as an obstetrician, I tell patients, you don't want your obstetrician to keep banker's hours. In other words, if you're in labor, you don't want them at 4 o'clock to say, well, you've been in labor for 2 hours and we haven't had a baby yet, so
I'm going home and drinking.
I'm done, and I'll come back and we'll do your C-section. So you want them to be patient.
Okay, so someone who's kind and gentle, and we have just a few minutes left. I do want to mention real quick about you and the fact that you are accepting new patients. Where can people find you?
Right, so I'm at Willis Knight & Bossier with Women's Health Associates. I've got a great practice of doctors that I'm privileged to work with, but we're over there on the second floor of Willis Knight & Bossier.
All right, and what is your cesarean rate?
My cesarean rate is somewhere,
Cesarean rate.
my primary section rate somewhere south of 20%.
Look
I can't
at you.
put an exact number, but it's low.
All right, so you've got 5-star ratings on Yelp. It's good to know, good baby knowledge there. You're going to make sure mom and baby are doing well.
Absolutely.
I love it. So we have a little bit of time left. Anything that I've missed out or I'm not asking you when it comes to these pregnancies and just how someone can have the best delivery, the best baby experience ever?
I think a healthy dialogue with your doctor. It's very, very, very important.
And we've got 90 seconds left. Real quickly also, if we have an unusual menstrual period, does that add to trying to conceive or difficulty?
So, absolutely. So with 60 seconds to discuss it, I would say if your cycles are irregular, I would say there's a good chance that you're not ovulating on a regular basis, and if you're not ovulating regularly, it's going to make it more difficult to conceive. So that is something that, again, that's something that we'd have to look at in an infertility workup.
Okay,
sure.
So definitely make sure that you mention that to your physician when you're going in for that prenatal checkup and you're putting together that Wikipedia birth plan that you
yes, and they should be asking you that.
Downloaded on the internet. It was so nice getting to meet you here. Once again, Dr. Rodney Armand, Chief of Obstetrics with Willis Knight Health System.
Thank you, Luana.
And
nice
you're
to meet
located
you.
only in Bossier?
Only in Bossier.
Got one office with several doctors there working with you. So if you're not available and out on vacation, someone's going to take care of you. All right.
Absolutely.
Thank you so much for joining us, everybody. Thank you for watching today, and hopefully you'll have a great pregnancy. Again, he is accepting new patients right now. Have a blessed and wonderful day. We'll see y'all back here next month. Oh, we need to stretch it a little bit longer.
Okay.
Real quick.
Sure.
How many babies have you delivered?
It's got to be at least 1,500. At least 1,500.
Oh, you're
It's
an expert.
roughly 100 a year, so somewhere in that ballpark.
And keeping those C-sections low. Have a blessed day.